Welcome back, everybody. David here again with Med School Bootcamp. So in this chapter, we're going to talk about bone tumors and specifically primary bone tumors. And what do I mean by that? A primary bone tumor is one that arises at the bone cells itself. Compare that to when we say something is secondary, or a secondary bone tumor is going to be one that has metastasized or come from somewhere else. That is to say, a cancer has spread to the bone, right? The primary site is somewhere else. The bone is a secondary site. But this chapter, again, we're really going to focus on primary bone tumors here. We're also going to talk about the difference between a benign bone tumor and a malignant bone tumor. So there's lots coming in this chapter. We're going to talk about osteochondromas and enchondromas, osteomas and osteoid osteomas, osteoblastomas, giant cell tumors, osteosarcomas, chondrosarcomas, and we're going to wrap it up with the Ewing sarcoma. So if you all are ready, then off we go. So in this video, we're going to start by talking about two commonly tested benign bone tumors, osteochondroma and enchondroma. And what do I mean by benign? Benign tumors are typically confined to a certain area and do not spread to other areas, compared to malignant tumors, which are more likely to spread or metastasize in the body. So in these videos, we're going to focus on a few key points here. I want you to know the stuff that is highly tested, the stuff that will get you points on test day. So we're really going to focus on the epidemiology of these tumors, the presentation, as we always do, diagnostics, and management as well. There's a lot of little nitty-gritty details in there, but these are the main things that they're going to ask you about. These are the most likely things to show up on exam day. So when we think about the epidemiology here, we have our osteochondroma, which is the most common benign, again, we talk about what the benign means, bone tumor, and typically in a younger patient population, usually in that 10 to 30 age range. Contrast this with the enchondroma, which is the most common tumor of the hand. This is also typically in a younger patient population, although you'll notice that it's not quite as young. We typically said 10 to 30, and this is more that 20 to 50 range. Again, when I give these age ranges, this is not an exclusive. This is not a rule, right? It's more of a guideline. Again, when they give you board style questions, they like to give you a classic presentation. So I want you to think about what range might this show up in. This does not mean it's exclusive, right? It doesn't mean an 8-year-old can't have an osteochondroma. It just means in general, we're looking at this kind of age range, a younger patient population versus somebody in their 60s or 70s, let's say. Now, when we move on to the presentation here, you'll see that the osteochondroma is typically in the metaphysis of the long bones. And just as a quick reminder from anatomy, the metaphysis of the long bone is going to be that middle portion, right? We have the long portion, which is our diaphysis, the end portions, which are our epiphysis, in the middle portion, think M for metaphysis, is the middle portion of the long bone. And a key point about these bone tumors is that they're typically asymptomatic, but they can be painful to palpation. That is to say, a patient does not always come in with a obvious presentation, right? They don't always come in and say, hey, I think I have a bone tumor, right? It could be asymptomatic. They could come in with much lighter symptoms and say, hey, I've noticed a bump around my knee joint. And it's your job as the clinician to ask further questions and do a physical exam and realize that this may or may not be tender to palpation for the patient. Now, when we look at our enchondroma, we'll notice some similarities and some differences. A key difference here is going to be the location, and these are more likely to be seen in the medulla of the hand, most commonly in the feet, or in the distal femur. Again, this is going to be a similar presentation. The metaphysis and the distal femur can be similar areas on a bone, but if we're thinking about the hand, right, we're thinking more of an enchondroma versus an osteochondroma, more likely to be in a long bone. Again, a similarity here. These are typically painless, but they can present as a pathologic fracture in patients. And also, as we said, these are often located in the medullary portion of the bone. Again, the medullary portion of the bone is going to be this middle area right here. We have kind of the cortex on the outside. That's the hard bone. And then we have the spongy bone in the middle. The medulla, or the cavity, is more likely to be where we would find these tumors. Now, when we turn our attention to the diagnostics here, we want to be able to tell the difference between an osteochondroma and an enchondroma on imaging. And if you draw your attention over here, I've labeled them as such. We have the osteochondroma right here, which is going to be this sessile projection or pedunculated lesion that is near the metaphysis. Again, we talked about the location. This is typically in the metaphysis of long bones. And here it is, we see right here. We have a femur and we have the diaphyseal portion right here. This is going to be approximately the metaphyseal region. And then we have our epiphysis down here. So again, we're saying this is primarily a metaphyseal lesion, and that is where we are seeing this tumor or this growth occur. This is sometimes also referred to as an exostosis or bony outgrowth with a cartilaginous cap. So you can imagine there is cartilage around this tumor, kind of like we would have cartilage on the knee joint. At the end of the bones, we have cartilage. In this particular tumor, there's usually a cartilage cap on top of it as well. Now, to contrast that with an enchondroma, if we look at the X-ray imaging for that, we're likely to see a well-defined lucent medullary lesion. Again, focus on the medulla here as a contrast compared to this is more of a cortical lesion or in the cortex of the bone. And this typically arises from hyaline cartilage. So I just want to give you a second. If you take a look at this image over here, right, this is our enchondroma. Look at the image. Where do you think the tumor is located? That's right. It's likely this area right here, right? This kind of fits the things we're talking about. This is clearly a medullary lesion. Again, cortex is on the outside, medulla is in the middle. It's well defined, right? This is a very clearly defined circular portion right here in the phalanx. And so this is what something like an enchondroma would look like on imaging. We also talked about this tumor is most commonly seen in the hand, particularly the medullary portion of the hand, most common. And here it is, a classic example of it right here. Now, when we think about the management options here, it's going to be fairly similar for our osteochondroma and our enchondroma. If it's symptomatic, you do something about it. You consider a surgical excision. Same thing goes for our enchondroma. If a patient has symptoms, you do something about it. If they don't have symptoms, it's kind of just a wash and wait approach. Key thing to know here for the osteochondroma is that there is a small risk, about 1% risk of transformation into a chondrosarcoma, which is a malignant tumor. We have a whole video about that later on in the chapter. We'll talk about that. But in general, we said these are benign tumors. We don't really worry about them unless they're causing symptoms. However, with this particular one, the osteosarcoma, we have to keep a little bit of a closer eye on it because there is that small but possible chance that it can actually convert into a malignant tumor in the future. And again, if these tumors are asymptomatic, it's really more of a watch and wait. You don't have to do anything about them. You don't have to do anything invasive if they're not causing the patient any problems or if they're just discovered incidentally. So potential questions that the examiners could give you for this pathology include something along the lines of a 13-year-old boy presents to the pediatrician with a chief complaint of a bump on the right thigh just above the knee. The patient denies any symptoms of illness or trauma to the area. On physical exam, there is a palpable mass above the lateral joint line. The question could then ask which of the following imaging modalities would be most appropriate for further evaluation at this time. Well, for these particular findings, right, we're talking about kind of a non-specific lump or mass in the area that's asymptomatic for the patient. Well, the best imaging modality is going to be the radiograph or the x-ray, right? Because we can see these pretty classic findings. We don't need to jump to a CT. We don't need to jump to an MRI. An ultrasound might not give us as good of an image, particularly if we're talking about some of these medullary lesions. So the radiograph, the x-ray is going to be the fastest thing, the best imaging modality to begin working up this patient and potentially make a diagnosis of a primary bone tumor. So just a quick recap for this video. To start this chapter off, we're talking about primary bone tumors. Again, primary meaning it originated at the bone. We're talking about osteochondroma and enchondroma. We're comparing and contrasting. A lot of similarities here, right? These are both benign bone tumors, typically in a younger population, but we really want to think about the location here. Osteochondroma is most likely to occur in long bones, particularly metaphysis, whereas an enchondroma is more likely to occur in the hand. Again, there are some overlaps there where this can occur in the distal femur as well. Really, the key to differentiating these is going to be our diagnostics. We have to be really comfortable with these images. We talked about the osteochondroma having this sessile pedunculated lesion. Again, it's kind of hanging off the edge here with the cartilaginous cap, and the enchondroma has the well-defined lucent, commonly medullary lesion, again, in the medulla rather than in the cortex of the bone, which we see here. When we think about management, if these are asymptomatic, we don't need to do anything about them. We can just watch and wait. If they're causing symptoms for a patient, we can consider surgical intervention. Key here to remember for the osteochondroma specifically that there's about a 1% risk of malignant transformation into a chondrosarcoma, which would require more aggressive treatment for the patient. Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about another couple primary benign bone tumors, and that's going to be the osteoma and the osteoid osteoma. We're going to talk about how to compare and contrast these. Again, these are a type of primary bone tumor, meaning they typically arise within the bone themselves, versus a secondary bone tumor, which is a metastases from somewhere else. These are also considered benign, meaning that they don't typically metastasize to other areas or invade tissue in the body. Now, when we think about our epidemiology here, we talked about these being a type of benign bone tumor, which is important to keep in mind for when we talk about later on in the series are malignant bone tumors. When we think about the osteoma, this is something we'll classically see in middle age. So we're kind of thinking that 40 to 60 age range versus the osteoid osteoma, we're more likely to see in a younger patient population. Again, I say this every time. This does not mean we can only see this in this patient population, but most classically, when we think about board style questions, we want to think about classic presentation. This is typically the age range they'll give you for these questions. Now, when we move on to the presentation here, this is where we really start to differentiate these pathologies. The osteoma is typically going to be seen on the surface of facial and cranial bones. It's often going to have an asymptomatic presentation, and that it could just be a finding that's seen on imaging, but not what the patient came in for, or the patient doesn't have any actual symptoms of it, but they know that they have it. Additionally, it's associated with Gardner syndrome, which, if you recall, is a variant of FAP, or familial adenomatous polyposis. If you recall, FAP is an autosomal dominant condition due to a mutation in the APC tumor suppressor gene. This can lead to a significant amount of polyps in the GI system that have a high risk of malignant transformation. Now, when patients have this condition, and they also have osteomas in the body, this is considered a variant of the FAP, and we call this Gardner syndrome. So it's essentially FAP with bone or soft tissue tumors in the body as well. Now, if we contrast that with our osteoid osteomas, we see the location is likely to be different. These are more likely to be seen in the metaphysis and the diaphysis of the long bones. Again, the diaphysis is the long portion of the bone, the metaphysis is kind of the middle portion, and then the end is kind of the epiphysis of the bone. Now, another couple key points about the osteoid osteoma is that the pain is typically worse at night. And a high yield thing that I really want you to know, because it helps us contrast with another pathology, is that the symptoms are typically relieved by NSAIDs. Why is this so important? Why did I include a high yield? Because there's another similar bone tumor we're going to talk about in another video called an osteoblastoma. And in this bone tumor, pain is not relieved by NSAIDs. So again, it's a very classic way that they like to ask this question, which is why I'm highlighting this. They'll talk about a bone tumor, they'll make it very obvious that's what the patient has. But then they'll have that little caveat somewhere in the question stem. They'll say patient takes NSAIDs or anti-inflammatories, and it does improve their symptoms, more indicative of an osteoid osteoma, or it does not improve their symptoms, more indicative of an osteoblastoma. This is a key differentiating point, which is why I'm highlighting it here. Now, when we talk about the diagnostics here, we have the osteoma, which you can see over here, and this is most commonly going to be a hyperdense, well-demarcated, smooth, bony mass. So you can see this area right here. It's hyperdense, so it's really white on imaging. This is a CT scan that we're looking at. It's well demarcated, right? It's very circular in its appearance, and it's a smooth bony mass, right? It doesn't have a bunch of jagged edges. It's a very smooth circular appearance. Now let's contrast that with an osteoid osteoma, which we'll also look at on CT scan, and we can see it over here, which is going to show up more as a radiolucent osteoid core with surrounding perifocal sclerosis. So what's that mean? Well, we have this mass over here, right? We have the arrow. We have kind of an osteoid core with sclerosis around it, right? This white area is sclerotic and it is surrounding the tissue. And so you can see that pretty clearly on the imaging here. And here is another key differentiating point. Again, osteoid osteoma and osteoblastoma, they like to ask you about those two because they're very tricky. We talked about the difference in NSAIDs, right? Now here's another key point in that osteoid osteomas are typically going to be smaller than an osteoblastoma. Osteoblastoma, I think of a big blast, right? It's big, it's an explosion. I think blastoma equals big. That's typically going to be greater than 2 centimeters. But here in the osteoid osteoma, it's smaller. So it's typically in that smaller than, or it's typically less than 2 centimeters on imaging. Again, they might give you this in a question set. They might talk about the imaging. They might not show it to you, and they'll talk about the size of it, and they'll want you to differentiate the osteoid osteoma versus the osteoblastoma. Now, when we move on to our management options here, for an osteoma, you typically will take it out surgically if it's symptomatic and extensive. Again, a lot of these primary bone tumors, if they're not causing any symptoms, they're not a big deal, right? It's really if it becomes symptomatic that we start having to treat them or remove them from the patient, or in some of them that we worry about malignant transformation. When we look at the osteoid osteoma, we talked about the importance of anti-inflammatories for symptom management and that these do respond to anti-inflammatories versus the osteoblastoma, which does not. And these patients can also have surgical removal as well if needed. Again, if it's asymptomatic, it's not causing problems, we don't go chasing it. We don't go and do an interventional thing. If it's causing symptoms, then we have that discussion a little bit more with our patients. Now, a possible question stem they could ask you about to really talk about some of these pathologies includes something along the lines of a 21-year-old patient presents to the clinic with a chief complaint of left knee pain that is worse at night. The patient denies any symptoms of illness or known trauma to the area. On physical exam, there's a palpable, painless mass above the lateral joint line, and radiographic imaging shows an approximately 2 centimeter radiolucent core with surrounding hyperintensity. The question can then ask which of the following treatment options would be most useful for helping this patient's nighttime pain. Well, the answer is going to be the anti-inflammatories, right? They talked about the imaging. We said it was 2 centimeters, so it doesn't really give you a clear differentiation. Is this osteoblastoma versus osteoid osteoma? It's right at that 2 centimeter mark. But what the imaging does tell you is that there's a radiolucent core with surrounding perifocal sclerosis, or the hyperintensity, right? This white stuff around it, this hyperintensity is this key defining feature of the osteoid osteoma. We know this is a tumor that's responsive to anti-inflammatories. So when asked about treatment options, we always want to start with the most conservative thing. We would consider anti-inflammatories in this instance. Now, just a quick review of this video. We're talking about osteomas and osteoid osteomas. These are both primary bone tumors, and they are benign bone tumors, right? They're not typically malignant. They don't spread throughout the body or get into the surrounding tissues too much. We have the osteoma, which is typically in middle age, versus the osteoid osteoma, typically in a younger patient population, but not always. We have the presentation, which is different. The osteoma is typically in the facial or cranial bones. Key association here with FAP, which we call Gardner syndrome, if they have the combination of FAP, the colonic polyps, with the bone and soft tissue tumor findings. Contrast osteoma's facial and cranial involvement with osteoid osteoma's metaphyseal or long bone involvement. Again, different locations to differentiate these tumors. When we think about the diagnostics here, right, the osteoma is going to have that hyperdense well demarcated smooth area versus the osteoid osteoma is going to have the radiolucent osteoid core with the surrounding sclerosis or the white area, the hyperintensity on imaging findings. When we think about the management here, again, with these primary bone tumors, if they're asymptomatic, we don't worry about them. We don't go chasing them. But if they are symptomatic, you can consider surgical removal. Key point here for osteoid osteoma to remember that this is responsive to anti-inflammatories. Why is this important? Because we're going to talk about contrasting it with a different bone tumor in an upcoming video, the osteoblastoma. Osteoblastoma is not relieved with NSAIDs. Osteoblastoma, again, blast big, is typically greater than 2 centimeters versus the osteoid osteoma is relieved with NSAIDs, and it is typically smaller, typically less than 2 centimeters. So these are a good way to differentiate these in your mind as key defining characteristics. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about another primary bone tumor, which is also benign, and that is the osteoblastoma. Remember, in a previous video, we talked about the osteoid osteoma. Key point that we need to be able to differentiate these two bone tumors from one another. So when we talk about the osteoblastoma, let's jump in with the epidemiology. And we said that this is a benign bone tumor, and it's typically going to affect males more than females in a younger age range, approximately the 10, 20-year-old age range. So again, this is important to keep in mind. Classically, a presentation is not going to be a 7-year-old patient who has this for the first time. It's most often going to be a teenager or a young adult. But again, this is not always the case. When we think about the presentation here, this can present with localized pain plus or minus swelling. This is really important because some of the other bone tumors we've talked about, right? The osteochondroma, the enchondroma, the osteoid osteoma, and the osteoma in previous videos, we talked about these kind of being asymptomatic or painless bone tumors. They might cause some symptoms, but not usually. They're more likely just to be felt as a mass in the body. But here we have a tumor, right? An osteoblastoma, which is actually going to have some pain present. And again, I think about kind of a memory aid here to think about the blast, right? I'll talk about a couple different things here, but the blast, if you think about a blast occurring, it's going to be painful. So the osteoblastoma is when I think about classically being a painful bone tumor. Now, another key point for this presentation is that this may cause neurological symptoms, and this will make sense to us in a minute when we talk about our diagnostics here. But the idea is that these tumors are most likely to be seen in the vertebra. And we know that the vertebra is surrounding a very important structure inside, which is our spinal cord. And if we have a tumor that is surrounding our spinal cord, the compression on the nerves can actually lead to neurological symptoms in a patient. Now, when we think about the diagnostics here, it's important to note that on X-ray, this is typically going to be a cortical bone tumor. Again, we talk about the cortex of the bone is kind of the outer portions of it, and then the inside is the medulla, the spongy bone, right? And so if you draw your attention over here to this X-ray imaging, we can see a very classic osteoblastoma present. We have a vertebra present and an outgrowth. On this side, we have normal appearing bony contours, but over here, we can see a very large expansile lesion. Again, this is a growth that is at the spinal cord. This is specifically at the cervical spinal cord. And so as you can imagine, this compresses, right? It gets bigger and bigger. It's compressing towards the central canal, which is housing our spinal cord. And that's why these patients could have the neurological findings. Now, we mentioned that this tumor is most commonly in the vertebra, but it can also be seen in the long bones as well. And here we have, again, another key differentiating feature from some other tumors that we talked about, and that the osteoblastoma is typically larger than the osteoid osteoma. It's typically greater than 2 centimeters. In the previous video, we talked about the osteoid osteoma being a bit smaller, typically less than 2 centimeters. And so again, if you think about a blast for a memory aid, right, it's painful and it's also large or greater than 2 centimeters. And so this is how I really can remember key portions of this bone tumor by thinking about the blast in the word. Now, when we think about the management here, a super key high yield point to know is that this does not respond to NSAIDs. Again, why is this important? Because we compare this to an osteoid osteoma, which does respond to NSAIDs. So again, thinking back to the memory aid, the word blast, I think it's painful, it's large, and it does not respond to NSAIDs. Again, you think about a blast, right? I think about a blast being a very big deal, a very big injury. And when I think about that as something that doesn't respond to just over-the-counter anti-inflammatories. And so those are the 3 key points here. The blast, I think of painful, large, and not responsive to NSAIDs. Now, as we said with previous bone tumors as well, the same rules apply. Surgical removal may be necessary if indicated for these patients, but this is a benign bone tumor in general, so that's not always necessary. What would be an indication for surgery? We'll think about it like this. If the patient is having a very large bone tumor that's causing neurological compression on the spinal cord, this can be an indication for surgical intervention. But if it's small, it's noticed on imaging but not causing any symptoms, you don't have to do anything about it. If it is causing symptoms, we have to think about the treatment options. NSAIDs would not be a good option because these tumors do not typically respond well to anti-inflammatories. So a potential question they could give you includes something along the lines of a 15-year-old patient presents to the pediatrician with new onset upper back and neck pain. The patient feels well overall and denies any known trauma to the area. He reports occasional numbness and tingling down the right arm as well. And the patient's mother reports they have been trying conservative measures such as stretching, ice, and anti-inflammatories, but these do not seem to improve the symptoms. The question could then ask, which of the following bone tumors is the patient most likely to have? Well, using our clues from this question stem, right? It does not improve with anti-inflammatories. It's causing right arm numbness and tingling, right? It's upper back cervical neck pain, likely to have involvement of the vertebra. Well, the most likely bone tumor that this patient has is the osteoblastoma. Again, there's tons of clues in there. Another key one is the age of the patient. If they talk about a 15-year-old patient, that really fits nicely into our typical or classic age range. So just a quick summary to wrap up this video. This is osteoblastoma. Again, we want to be able to compare and contrast these primary bone tumors. We want to specifically compare and contrast this to osteoid osteoma, which we talked about in a previous video. The epidemiology here is typically going to be seen in a younger patient, although not always. Presentation, we often have localized pain with swelling and potentially neurological complications. Why is this? Well, if we think about our diagnostics here, this is typically a cortical bone tumor that's most common in the vertebra. If we have the tumor in the vertebra compressing on the spinal cord in the canal, that is how we get these neurological symptoms. So again, it kind of fits here, right? The presentation of the patient fits with the location of the tumor. When we think about management options here, key point is to differentiate that osteoblastoma does not respond to anti-inflammatories versus an osteoid osteoma, which does respond to anti-inflammatories. A memory aid I like to use is to remember the word blast and blastoma. It's painful, which we talked about here. It's large, a blast. I think about being large. We talked about that here. And it does not respond to NSAIDs. I think about it being a big, painful blast that is not easily treated with anti-inflammatories. So that's how I kind of keep this tumor straight in my mind. Now, although NSAIDs are not useful for this particular condition, patients may be indicated for surgery, particularly if they're having these neurological compressions, if they're having nerve compression because the tumor is pushing on the spinal cord. That could be a possible indication for surgical intervention. Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about another very important primary bone tumor, and that is one called giant cell tumor. Sometimes this is also called osteoclastoma. And remember, osteoclastoma is a type of cell in the body that consumes bone. We often remember the C for consumes, and we compare that to something like osteoblastoma, where we remember that the B stands for build. So osteoblastoma builds bone, osteoclastoma is going to consume bone. And this will play a little bit more of a role later when we talk about the diagnostics and imaging and the types of cells we'll see in this condition. Now, I want to briefly draw your attention to this image over here. This talks about our primary bone tumors. And so one of the things I really want you to keep thinking about as we continue to go through this chapter is, where are these primary bone tumors most commonly located? Again, question writers are often going to give you a classic presentation. So this is a really nice image that you can use to differentiate where you might find these bones. Recall we have the diaphysis, which is the longest portion of the bone, the metaphysis, which is kind of the middle portion. I think of M for metaphysis as middle, and the epiphysis, which is kind of the end portion of the bone. I think of E and epiphysis for end portion. And depending on the tumor, we're more likely to see them in different parts of the bone. And so in this video, we're specifically focusing on the giant cell tumor, and you'll see this is kind of located in the epiphysis and the metaphysis. I want to talk a lot more about that pretty soon. But this is just a really nice image to use to kind of think about where's the location we're most likely to see some of these bone tumors that we've been talking about throughout this chapter. So when we think about the epidemiology for this condition, the main thing they want you to know is the age range. Typically, it's going to be approximately a 20 to 40-year-old. And again, I keep saying this, but this doesn't mean an 18-year-old can't have this or a 45-year-old can't have this tumor. But most often, this is kind of a younger to middle-aged patient population that we're going to see with this tumor. Now, when we think about the presentation here, this bone tumor is going to often present with localized pain with or without swelling. One of the common ways this actually presents is as a pathologic fracture. Somebody will break their leg doing something that wouldn't normally break their leg. That is to say, a pathologic fracture is due to a minor trauma or mild exertion. Let's say a patient lifts up a heavy box and has a femur fracture. We wouldn't typically see a patient break their femur from lifting something heavy, but in a pathologic fracture, they can actually break things with much less force than we would expect to see in other patients. Now, we will also consider that patients are going to have a decrease in range of motion. And again, this gets back to the fact that they can have some swelling in the area. And if we have swelling in a joint, that's going to decrease the amount that we can actually move that joint. And as we mentioned already, this is typically going to be seen in the epiphysis or the metaphysis of the long bone. So you can see right here, here's our giant cell tumor. I'm highlighting in orange. And here's the classic area that we're going to see this, how it kind of overlaps between two different areas. We have the metaphysis up here and the epiphysis down here. And so because of this classic location, this is commonly seen in the knee region or in the distal femur. And that's what we're seeing on this image right here. This is a femur, right? This is the proximal portion of the femur towards the head. The distal portion is more towards the knee, the foot, the ankle, further away from our center of our body. And in the distal portion, we see this classic area where the tumor can arise. Now, when we think about the diagnostics here, X-ray finding is often going to show an osteolytic multicystic lesion, sometimes called a soap bubble appearance. And again, this makes sense to us, right? Why does this make sense? Because we said this is also called an osteoclastoma. Osteoclastoma and osteoclast consumes bone, C for consume. So then we see that it's osteolytic lesions. Osteolytic meaning there's punched out bone lesions, which makes sense to us based on the name of the pathology. And I think this pathology is really important to what we talked about in a previous video, which is an osteoblastoma. Remember we talked about osteoblastoma as a big growth in the area, particularly looked at the cervical spine. And in that region, we had a very hyperdense bone growth. But here, if you draw your attention to the image, we can see something different. We can see a sclerotic osteolytic lesion. So here's the tumor right here. And you can appreciate that this is less dense, or it's less white than what you can see up here in the bone. Why? Because bone has been destroyed here. It's been consumed. This is an osteolytic lesion versus our osteoblastic lesion, which is going to be extremely dense, right? It's going to be hyper intense on imaging. But here we see the opposite. This is a little bit gray or a little bit darker of an appearance. So this is a classic finding of a giant cell tumor or osteoclastoma. Another key thing they like you to know for test day is about the histopathology here, and that we'll see multinucleated giant cells, increased macrophages, and increased stromal cells. So if you draw your attention to this image right here, we can take a closer look at what some of those findings might be. So if you look right here, you can see the classic finding of multinucleated giant cells. You can see a bunch of different nuclei in here. There's very dark purple, and this whole thing together is a multinucleated giant cell. And again, you can see another one right here. You can see another one right here. So this is a very classic finding on histopathology of the giant cell tumor. And I think of giant cell with the giant cells, right? That should make it easier to remember in your mind. You can also appreciate that there's hypercellular stroma in the surrounding tissue. So that's kind of the stuff that we would see right here. Another thing they like you to know, although less commonly tested, is that these are going to be rank L expressing neoplastic mononuclear cells. And this should make sense to us, right? Because recall rank L is an important receptor in the activation of osteoclasts, right? And this is an osteoclastoma. Osteoclasts are active. So it makes sense that we would have cells that have the rank L ligand. Now, when we turn our attention to the management here, fairly easy one to keep in mind, in that this is going to be requiring surgical intervention. This usually comes in the form of curettage, which is surgically scraping out or removing tissue from the body, in this case bone. And then bone grafting can be done as well for healthy bone to hopefully regrow in the place of the tumor. Now, a key thing that you need to know for this particular tumor is that there's increased risk of malignancy with increased age. That is to say, as patients get older and they have this tumor, there's more likely it could be malignant. There's more likely it could spread throughout the body. One of the classic places it would do this would be to the lungs. So a potential vignette that could give you to test these concepts could be something along the lines of a 33-year-old patient presents to the clinic with new onset right thigh pain. The patient reports he was helping a friend move to a new apartment, and when lifting up a heavy box, he heard a crack in his leg. On imaging studies, the patient is found to have a right distal femur spiral fracture that is located next to multiple osteolytic lesions. The question could then ask, which of the following cell types is most likely overactive in this patient? They can give a variety of different options, including lymphocytes, osteoblasts, osteoclasts, T helper cells, or really whatever they wanted. But the idea here is that this answer would be osteoclast, right? Because this is an osteoclastoma. They're saying that the patient has a pathologic fracture, right? Lifting the heavy box and has a femur fracture doesn't typically happen for most healthy individuals. This is considered fairly minor exertional activity to cause such a big fracture. And then the imaging showing that the fracture is near multiple osteolytic lesions, indicating this patient likely has giant cell tumor or an osteoclastoma. So just a quick summary to wrap up this video. We're talking about a giant cell tumor, also called an osteoclastoma. Remember, the C in clastoma stands for consumes bone. Really important to keep in mind because this helps us with the diagnostics and understanding the patient's pathophysiology here. Epidemiology, typically in a younger to middle-aged patient, presentation is going to be pain plus or minus localized swelling, and they often talk about these pathologic fractures, a fairly low energy mechanism that causes a fracture you would not otherwise expect in a healthy individual. When they talk about the location, they're most often going to talk about the epiphysis or the metaphysis of the long bone, so kind of the distal femur is kind of the classic place, although not the only place you can see this. When we think about the diagnostics here, osteolytic multicystic lesions. Why? Because this is an osteoclastoma. Osteoclastoma consumes bone. We talked about the imaging right here. It's kind of got that punched out, moth-eaten appearance versus something like an osteoblastoma, which is going to have a hyperdensity to the bone with more bone being built. B for blastoma indicates more bone is being laid down, but here we have C for clastoma, which indicates more bone is being consumed. For this one, they also like you to know the histopathology, particularly the multinucleated giant cells. We talked about this in the image right here. These kind of cells right here, where a bunch of nuclei are conglomerated together, is the classic multinucleated giant cell finding. When we think about the management here, it's really going to come down to surgical intervention. You're often going to need to do some surgical removal of bone and some bone grafting to help these patients in the long run. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about another very important pathology, And this one is called osteosarcoma. So if we can draw your attention to our kind of overview image of the primary bone tumors, which shows the locations that these tumors show up, we can see the osteosarcoma is located in this area right here. And so that's primarily going to be in that metaphysis region of the long bone. And again, this is important because a lot of times they will give you the tumors, right? They will let you know it's a bone tumor, and they'll differentiate them by where they're located. Are they in the diaphysis, or the longest portion of the bone? Are they in the metaphysis, or the middle portion? Remember the M in metaphysis for middle. Or are they more likely to be located at the epiphysis? And again, the E in epiphysis for the end of the bone. This is a really important differentiating factor between these bone tumors, and that's why it's so important to know where's the primary location, where's the most likely location in the bone for these tumors to form. And so if we think about the epidemiology for the osteosarcoma, this is a malignant bone tumor. A lot of the previous tumors we've talked about in this chapter have been benign bone tumors. But here we're starting to talk about malignant things. In general, things that are malignant are more likely to spread or metastasize throughout the body or become locally destructive to the surrounding tissues. And so we'll see when we talk about the management here, these are more likely things that need to be treated a little bit more aggressively with surgical intervention or potentially chemo and radiation. Contrast that with some more benign tumors where we said if they were asymptomatic, the patient may not need treatments. If a tumor is just found to be there and it's not causing any symptoms, it's a known benign tumor, it's not likely to keep growing and become a problem for the patient. It could just be there and remain, or watchful waiting can occur until things change. But with a malignant tumor, we have to think a little bit more further down the line and think that these tumors are likely to cause bad problems for these patients, so we need to address them as soon as they are found. It's also important to know that this is going to have a bimodal age distribution, typically around 10 to 30, so teenage years to young adulthood, and then greater than 60 or some of our older years. And what that means is if we think about it, right, there's essentially a low incidence of patients having this disease, and then there's a spike. There's a lot of people that are having this in the 10 to 30 range, and then it kind of quiets off in that 40 to 50 range, and then there's another spike again. We call this bimodal. Bi means two, and we have two primary areas where this disease pops up again. As I always say, this does not mean that 40-year-old can't have this disease, but classically, these are the typical age ranges we think about for patients having this condition. Now, they also like you to know that patients can have primary osteosarcoma, which has an unknown etiology, as in we don't know where it comes from. It's just the primary disease that the patient has. However, secondary osteosarcoma typically is related to a patient having some other condition. So patients who have Paget disease of the bone, patients who have radiation exposure, bony infarcts, potentially retinoblastoma, Li-Fraumeni syndrome, or patients at elevated age are more likely to have this condition as well. It's a secondary condition, or a secondary osteosarcoma. There's one of these things going on. This is the primary condition, and the osteosarcoma is the secondary thing. It's because of one of the primary things, they have the osteosarcoma. So hopefully that makes sense. And just as quick reminders, Paget disease of the bone, remember, is characterized by rapid and progressive bone turnover. There's so much bone turnover that a bunch of bone gets formed, but it's poorly formed bone. And so it makes sense to us, right? If excessive bone turnover is occurring or extra bone formation is occurring, well, what could happen? You could develop a bone tumor, such as an osteosarcoma. Patients who have excessive radiation are also at increased risk, or patients with bony infarcts. So bony infarcts could be due to trauma to the area. Recall, corticosteroids can cause osteonecrosis or other things that can cause interruption to the blood supply to the bone, can increase a patient's risk for osteosarcoma. Retinoblastoma is an ocular genetic condition which is associated with the tumor suppressor gene RB1, where patients can get tumors in their eyes, and they can also get tumors other places in their body, such as their bones. And then finally, Li-Fraumeni syndrome, recall, is an autosomal dominant condition where patients get an inherited mutation of a tumor suppressor gene, TP53 in this case, and they are basically predisposed to all kinds of tumors and cancers throughout the body. Now, when we think about the presentation here, we talked about the region this typically presents. It's usually in the metaphysis of the long bone, near the knee region. And so again, this is why it's important to know specifically where in the long bone, because a lot of the tumors we've talked about, we say they're kind of developing in the tibia or in the femur near the knee region is where they like to test these. And so we need to specifically know which part of the bone, diaphysis, metaphysis, or epiphysis. So in this instance, we are most likely to be dealing with the metaphysis. As with many other tumors, this can have localized pain, which can be worse at night. This can include swelling and decreased range of motion. Again, if you have more swelling in the joint, that can decrease the amount that you can move the joint or decrease the range of motion. These patients can also have pathologic fractures, and we've talked about that previously, but just as a reminder, a pathologic fracture is a fracture that would occur in a scenario we wouldn't otherwise expect it to occur. So a possible example is somebody takes a step off of a stair. We walk downstairs all the time. Usually you don't break your leg. But if somebody steps down the stair and fractures their femur, this is a low energy mechanism of action for a fracture to occur. And so when things like this occur, when a fracture occurs to a very minor injury, this is often due to underlying bone disease or poor bone formation, leading to the fracture or predisposing the patient to having higher risk of the fracture occurring. Now, it's also important to know these patients could have potential B symptoms, right? And recall our B symptoms are fevers, night sweats, and unintentional weight loss. At the end of the day, this is a cancer, right? It's a bone cancer. It's different than our blood cancers. It's different than a brain cancer, but it's still a type of cancer. And so B symptoms are definitely things that patients can present with, and they would require further workup from the clinician. Now, if we turn our attention to the diagnostics here, some really high yield and important things they like you to know on test day. So they want you to know the imaging findings, or the x-ray in this instance, and the histopathology, in addition to some of the serum labs. So if you draw your attention over here to our x-ray, there's going to be some key findings they want you to know. First, let's orient ourselves. Up here, we have what bone? The femur. Up here is the kneecap or the patella. Here we have the tibia. And over here, this skinny bone is the fibula. So now that we've kind of oriented ourselves, let's talk about some of these findings. The first is going to be the sunburst pattern. And some of these kind of overlap with each other. They just have similar names. But the sunburst pattern refers to a pretty unique finding. So if we're looking at the tumor right here, the sunburst pattern is what's defined as a periosteal reaction that lifts the periosteum from the bone. And so this occurs when the bony lesion grows too quickly that the periosteum essentially can't keep up. And you'll kind of see this spiculated appearance, or these kind of fibers of bone tissue that are pointing out like this. So the idea is that it looks like a sun that's kind of coming over the horizon. And again, this is due to an incongruence between the rate of the tumor growth relative to the periosteum. The periosteum can't keep up. The tumor gets bigger and bigger and bigger. And as it does, the bone essentially stretches out this way, leading to this sunburst appearance, or these fibers that are being elongated in the bone. Now, when we think about K.A.N triangle, this is due to the periosteal elevation as well. Again, kind of a similar thing. And this is again referring to kind of that periosteum that's being elevated from the bone itself. So same thing over here. We can appreciate up here we have normal bony contour, and then we see this stark elevation, or this increased rise in the periosteum. So this is kind of the idea of the K.A.N triangle. And finally, we have osteolysis, which can also be called a moth-eaten appearance. And you'll see we have this in a few different tumors, right? Anytime we have osteolysis, it can kind of present this moth-eaten appearance. So if you kind of look at this whole thing, you can see how there's some really white areas and then some kind of darker areas. And so this is the appearance that has kind of been eaten at by moths, or that moth-eaten appearance. And this is again due to osteolysis. Bone is being destroyed in certain areas, or osteolysis is occurring, and that's what's creating these areas of darkness, right? Remember, on a classic radiograph or an x-ray, areas of darkness are not going to be bone typically, whereas the lighter or whiter areas are going to be our bone. Now, when we think about the histopathology here, they want you to know this is going to have pleomorphic osteoid-producing cells, sometimes also called malignant osteoblasts. So what does that mean? Well, let's draw attention to our pathology image right here. So first, they're saying these are pleomorphic. Pleomorphic just means that it's variable. It's variable shape, size, and staining patterns. So the key ones I want you to draw your attention to is this area right here. So you can appreciate some of these cells stain darker or lighter than others, right? There's also variation in the size. Just look at this bunch right here. Some are smaller than others. Some are larger than the ones next to them. And shape. Some of them are more circular shape. Some of them are more oblong or oval shaped. And so that's what pleomorphic means here. Now, these are osteoblasts. And what does that mean? They build bone. Remember, the B in osteoblast stands for build versus the C in osteoclast stands for consumes. So these are malignant, right? Because these osteoblasts are building too much bone. They're building excessive. That's why they're called malignant osteoblasts. A normal osteoblast is helping bone remodel. It's good. But when it gets out of control, when it gets to be too much, now we've created a bad process. We've created a malignant process in the body. And so if you see a question stem referring to pleomorphic malignant osteoblast, this is typically what they're referring to in that question. And finally, it's also important to know that you can have elevated ESR, LDH, and alkaline phosphatase in this condition. Again, this is not going to be as specific for this pathology, but it could be a supplemental piece of information that the question writers give you to kind of nudge you in the direction of the osteosarcoma. And just as a real quick reminder on what these are, alkaline phosphatase is an enzyme that's found throughout the body, particularly in bone. And so when we have extra bony processes occurring or bone tumors being formed, it's reasonable to think this could be an elevated enzyme near that area. LDH, remember, is lactate dehydrogenase, and ESR is our erythrocyte sedimentation rate. And this is a serum marker that can be elevated in a variety of different conditions, including infections, inflammation, or malignant conditions. Now, when we think about our management here, remember, we said this is a malignant bone tumor. So we're going to have to think a little bit more aggressive than some of our benign bone tumors. And the key here is that it depends if this is a primary cause or a secondary cause. We talked about this earlier in the video, right? Draw your attention back up here. We said that primary cause unknown, secondary cause, lots of potential etiologies. But the key point is that the primary cause is going to respond to surgery and chemotherapy. It's often resistant to radiation therapy, but the point is that we have good treatment options. We have things that we can do to help out these patients. In contrast, our secondary causes have a poor prognosis. The things that we can do to treat these patients don't seem to work near as well. So if these are one of the underlying reasons for the patient having osteosarcoma, overall, the long-term prognosis currently is going to be worse than somebody who has a primary osteosarcoma or an osteosarcoma that is not due to something else. So a possible question then they could ask you for this condition includes something along the lines of an 18-year-old patient presents to the ED with distal thigh pain for the last several weeks. The pain is progressively worsening and affecting his ability to sleep comfortably at night. On physical exam, there's tenderness and swelling around the affected area. The question could then ask which of the following imaging modalities would be the most appropriate to work up this patient's chief complaint. Now, they can give you a lot of different imaging modalities. They can give you a CT scan, they can give you an X-ray, an MRI, and an ultrasound. The key here that the answer for this question is going to be the radiograph or the X-ray. It's going to be the simplest, it's going to be the fastest, and you're going to be able to notice something like this on a radiograph. You don't necessarily need a CT for this. It's not a soft tissue thing. And again, an X-ray is the fastest, least expensive option to primarily work up this patient's condition. Now, that's not to say you can't get an MRI down the road for surgical planning. If surgical removal were indicated, right, a patient were going to have surgical intervention, then an MRI could be indicated. But the first thing you want to do, particularly in the setting of the emergency department, is to get an X-ray image of the patient's affected area. All right, so just a quick summary of this video. We're talking about the osteosarcoma here, right? This is one of our malignant bone tumors, has a bimodal age distribution. We talked about what that means. Primary osteosarcoma has an unknown etiology. Secondary osteosarcoma has many potential etiologies. Presentation here typically going to occur in the metaphysis of the long bone, often near the knee region. Patients are often going to present with pain, swelling, and decreased range of motion, and potentially could be presenting with a pathologic fracture. Plus or minus some of the B symptoms, right? Fevers, night sweats, weight loss. Because this is a cancer, although it's a bone cancer, patients can still present with these classic cancer symptoms. Diagnostics here, key points to keep in mind, the X-ray findings, right? We talked about what those are over here. This is very obviously the pathological region, but here's a couple of buzzwords they like you to know: the sunburst pattern, the Cosman triangle, and again, these are all due to the periosteal reaction. Bone is growing too much outwards, periosteum cannot keep up, and then we get some of these classic findings. Patients can also present with some osteolysis that presents with a moth-eaten appearance. Histopathology, we have pleomorphic, right? Varies in size, shape, and staining. Osteoid-producing cells, often called malignant osteoblasts. Why are they malignant osteoblasts? Because they're osteoblasts that are building too much bone or an excessive amount of bone to the point that it's considered to be a malignancy. When we think about the management here, primary causes are going to respond well to surgery and chemotherapy. Secondary causes are going to have a poor prognosis relative to primary causes. For the management here, right? Primary causes are going to respond well to surgery and chemotherapy. However, secondary causes are going to have a poor prognosis. Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about another important bone tumor, and that is chondrosarcoma. So let's break down the word here. Chondro is the Greek prefix for cartilage, whereas a sarcoma is referring to a malignant tumor of mesenchymal or connective tissue origin. And so altogether, a chondrosarcoma is essentially a malignant bone tumor that arises from mesenchymal cells or connective tissue cells that ultimately produces cartilage. And so that will kind of clue us into some of the key things we need to know about this tumor going forward. So if we turn our attention to the epidemiology here, this is going to be a malignant bone tumor. Remember earlier in the chapter, we talked about some of the benign bone tumors. Now we're kind of talking about some of the more malignant bone tumors. Typically, it's more common in men than women, and usually in an older population, approximately greater than 50 years old. So we wouldn't typically see this tumor in a 5-year-old. And as always, this is important to keep in mind because on board style questions, they often give you classic patient presentations. What's the classic age range? What's the classic findings? What's the classic diagnostics? That's how they really like to test these on board style questions. We also need to know that you can have a primary chondrosarcoma, which has an unknown etiology, and a secondary chondrosarcoma, which is typically due to pathogen disease of the bone, radiation, or potentially an osteochondroma. Now, recall, we had a whole video about osteochondroma, that this was a benign bone tumor. However, we said that approximately 1% of osteochondromas can actually turn into a chondrosarcoma, which is a malignant bone tumor. So here it is right here. Somebody who has an osteochondroma does not necessarily need surgical intervention right away, but you need to watch it closely because of that potential for the benign tumor to become a malignant tumor, such as a chondrosarcoma. Now, when we think about the presentation here, this is typically going to be found in the medullary portion of the femur, humerus, pelvis, or the bones. Remember, when we think about the bones, right, we have the cortex or the outer portion of the bone. That's kind of the hard, thick portion. And on the inside, we have the medullary portion, the spongy bone. This is where our blood cells are typically formed. And so as always, location of these tumors matters. Some of the tumors that we've talked about so far are located on the cortex, right? They grow out kind of at this portion right here. And some of the other tumors are going to be present more in the middle. Also important to note for these tumors that they can have localized pain and swelling. And this pain is typically worse at night. Additionally, these patients can have pathologic fractures. Again, a pathologic fracture is a low energy mechanism that results in a fracture, which you would not typically expect to see in otherwise healthy bone, right? If somebody's femur snaps when they lift up a heavy box or when they step down the stairs, that's considered a pathologic fracture. A normal healthy bone does not break under those circumstances. Normally to break a femur, it requires a high impact trauma to the area, but stepping down the stairs is considered a low energy mechanism of action. So if a bone breaks in that situation, it's typically due to an underlying pathology or poor bone that's actually formed in the area. So it's something to look into a little bit closer. Now, when we think about the diagnostics here, we'll draw our attention to our images over here. And I want you to really appreciate two key findings. First is osteolysis. Again, we get that moth-eaten appearance. And that's what we're going to see in this image right here. You can see this is a moth-eaten appearance. There's some areas that are kind of whiter than others, other areas a little bit more dark. It kind of looks like it's been picked at or it's been eaten. This moth-eaten appearance, this is due to osteolysis, which is the destruction of the bony tissue. So if you compare it to the bone over here, right, it's just very white, looks like good solidified bone. And then you look at this right here, it's not quite appearing to be the same way. It looks a little bit softer, a little bit less dense. And this is the classic finding you can see in these patients. The other classic finding you can see are these intralesional calcifications, sometimes called popcorn calcifications or said to have a popcorn appearance. So if you look at our image in the corner, you can see this lesion right here, right? You can appreciate how this kind of looks like a piece of popcorn. It's a very obvious calcification or lesion within the bone. This is another classic way that this can present. So we can either have the osteolysis, moth-eaten appearance, or the intralesional calcifications. Both of these are consistent with a chondrosarcoma in the right clinical setting. Now, also important to know the histopathology here is going to include peripheral calcifications with hyaline cartilage nodules and malignant chondrocytes. So draw your attention to this histopathologic image right here, and you can appreciate a handful of things. So these are chondrocytes, right? These are cartilage producing cells. They're malignant because we're producing too much, right? Remember, chondrosarcoma is a tumor with too much production of cartilage. And so whereas a chondrocyte is a normal cell in the body that's producing cartilage that we want, a malignant chondrocyte is one that's overproducing or producing too much of something, creating a cancerous lesion. Now, these patients are also going to have what are peripheral calcifications, and that's what you see right here. And so you see kind of this normal appearing bunch of cells over here, free floating, and then you kind of see this super dense area. This is an area of calcification, which is a classic finding in a chondrosarcoma. When we think about the management for these patients, recall this is a malignant bone tumor. So surgical excision is often needed, plus or minus chemotherapy and or radiation therapy. Overall, it's important to note this has a low metastatic potential. However, even though the risk is low, the risk is not zero, and so it still needs to be treated accordingly to help these patients in the long term. So a potential vignette they could give you for this type of pathology includes something along the lines of a 68-year-old patient presents to the clinic with 2 months of right leg pain that is worse at night. The pain is most notable in the distal thigh, and there's a mild effusion on physical exam. Vital signs are within normal limits for this patient. An x-ray is taken of the leg and knee, which shows multiple cystic lesions in the distal femur. Question could then ask which of the following is the most useful to treat this patient's condition. They could give you a lot of different options. They could talk about pain control. They could talk about watchful waiting. They could talk about some invasive testing or imaging. But the best answer for this particular condition would be to refer this patient to an orthopedic surgeon or an orthopedic oncologist for potential surgical excision. Now, I know a lot of times on board-style questions, we say, you don't typically want to refer, right? It's kind of a classic test-taking strategy. Usually referring to a specialist is not the first thing you want to consider in a board-style question. But if you can rule out the other options, right? If you know this patient likely has a chondrosarcoma based on the classic findings that you heard about in STEM, you know that pain management is not going to be enough. You know that more imaging is not necessarily going to treat the patient's condition. This is a type of malignant bone tumor. That's what they want you to appreciate. A malignant bone tumor likely needs surgical excision and potentially some oncologic therapy as well. So in this instance, if you can rule out the other options, it would be best to refer this patient to a specialist to help treat their condition. So just a quick summary of this video, we're talking about the chondrosarcoma, a malignant bone tumor that typically occurs in older adults. Primary chondrosarcoma has an unknown etiology, but secondary chondrosarcoma can be due to a variety of conditions such as Paget's disease of the bone, radiation, or that osteochondroma. Remember, about 1% of osteochondromas, which is a benign bone tumor, can become a chondrosarcoma, which is a malignant bone tumor. When we think about the presentation here, this is typically going to be in the medullary portion or the middle area of the bone rather than the cortex on the outside. As with a lot of other bone tumors, this can present with pain, swelling, or pathologic fractures. Diagnostics, 2 key points to keep in mind: the moth-eaten appearance that you can see or the intralesional calcifications with the popcorn appearance as well. Histopathology is going to include malignant chondrocyte as well as areas of calcification. And the management for this condition is going to typically include surgical excision with or without some chemotherapy and radiation. So the key here is that patients need to see a specialist for this condition because it's a malignant bone tumor for further workup and evaluation. Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about a bone tumor called Ewing sarcoma. And Ewing sarcoma is going to be one of our primary bone tumors that's most often located in the diaphysis. So you can see it right here. We have our Ewing sarcoma, myeloma, our osteoid osteoma, as some of our primary bone tumors located in the longest portion of the long bone. We want to be able to contrast this with some of the tumors located in the metaphysis, such as the osteosarcoma and osteochondroma, And then those are located in epiphysis, such as the giant cell tumor. Notice giant cell kind of has overlap between the epiphysis and metaphysis. But this is really important for testing because a lot of times they're going to give you some kind of imaging, either a CT scan or a radiographic image, an X-ray. And if you know which tumors are more likely to be located in certain parts of the bones, it can help you narrow down your differential to determine what's the best answer or what's the condition that it has. So for Ewing sarcoma, if we think about the epidemiology, this is going to be one of our malignant bone tumors. Again, early in the chapter, we talked about some of the benign tumors. Now we're talking about more of the malignant bone tumors. These are a little bit more serious, a little bit more invasive and destructive to the tissue, and more likely to metastasize to other areas in the body. This is classically going to be seen in a younger aged population, typically 10 to 20-year-olds, specifically in white males. And it's important to know that this is an aggressive tumor with early metastatic potential. So earlier we can catch this, the better, because this is a tumor that is likely to metastasize to other areas in the body. This is a really important point to note because it can contrast with the previously talked about pathology, the chondrosarcoma. We said the chondrosarcoma has an overall low metastatic potential. And so it's important to keep this in mind as we're kind of building differentials and we're thinking about questions they could ask. They could ask us about which tumors have a low metastatic potential, such as chondrosarcoma, versus the higher or early metastatic potential, such as sarcoma. Now, when we think about the presentation here, we talked about how these are most likely to be seen in the diaphysis of long bones, specifically the femur, or they can be seen in flat bones, such as things like the pelvis. Similar to other bone tumors, this is likely to present with localized pain and swelling, and these symptoms can be present. Remember, these are our fevers, night sweats, or unintentional weight loss. Why? Because this is a type of cancer. This is a type of bone cancer. We often associate our B symptoms with cancers in the body, but this could be a blood cancer, this could be a brain cancer, or in this case, a bone cancer. Now, when we consider our diagnostics here, a couple key things I want you to note. When we look at the X-ray finding, which we'll see over here, I want you to notice two key things. First, the lytic bone lesions, and we've talked about this previously. If you compare this bony area right here, it's a lot wider than the bony area below it. I kind of highlight that in light green. You can see this is a little bit darker, indicating some osteolysis of the bone has occurred. That's why it does not appear as white as other portions of the bone. Now, the onion skin appearance is another classic buzzword that they use, and this is referring to the periosteal reaction that is occurring. So you can see it's kind of being elevated from the bone. If you look right here, you can see a little bit of a hump relative to what we're seeing in the distal portion, which has more of a smooth contour. And so the idea is as the periosteum kind of builds itself outwards, it gives this onion-shaped appearance. Now, if we turn our attention to histopathology, we'll see anaplastic small blue cells that have a neuroectodermal origin. So I want to draw your attention to this image right here. And we can look at all of these cells, which are called anaplastic, meaning they've lost their normal cell morphology. You can also appreciate that there are a lot of blue cells in here, right? We have kind of the purple background, but a lot of these cells are blue, and that's why they're called anaplastic small blue cells. Important to note that these look similar to lymphocytes. And so it's important to note that this histopathology can also be seen in things like lymphoma or chronic osteomyelitis. And so I've highlighted that here as well. You must be able to differentiate these cells from the lymphocytes in lymphoma or chronic osteomyelitis. You have to use the full clinical picture, right? They just give you this image. It's not enough information to determine what's the patient's condition. They have to give you some other clues about the patient's history or their symptoms, or potentially a radiographic finding that indicates that we're dealing with an Ewing sarcoma in this case. Now, a really important thing they'd like you to know at this level is our chromosomal translocation. So the classic one here is going to be the translocation at T11 and 22. This is going to result in a fusion protein that ultimately increases cellular proliferation. An increase in cellular proliferation can lead to a bone tumor or a growth of a mass. This should make sense to us, right? So we have a fusion protein that increases cellular proliferation, well, we can have an increasing growth of tissues, such as a bone tumor. Now, one of the best memories I know to remember this 1122 translocation is to think of a famous former basketball player, Patrick Ewing, because Patrick Ewing wore number 33 when he played basketball for the New York Knicks. Now, this is helpful, right? Because 11 and 22, the translocation, well, 11 plus 22 equals 33. So if you can just remember Patrick Ewing, who's a famous basketball player for Ewing sarcoma, you have that memory in your head and you think about he wore number 33, and then you can remember the translocation as 1122. 11 plus 22 equals 33. So it's a nice simple memory aid to help keep this in your brain for test day purposes. Finally, some other non-specific findings you can see include serum labs with an increased ESR, LDH, or leukocytosis. Now, when we move on to the management here, this is a malignant bone tumor, so it's going to warrant surgical resection plus or minus chemotherapy, depending on a variety of factors, including whether or not it's metastasized. It's also important to note that radiation therapy can be considered in some cases, but this is something that a specialist will decide on for the patient. So a classic way they can test this pathology on exam question includes asking you something along the lines of, a 13-year-old boy accessed the pediatric clinic
with 1 week of worsening pain and swelling below his left knee. He denies any recent trauma to the area or falls. Patient reports he feels well overall, but has had intermittent night sweats over the past couple of weeks. Vital signs are within normal limits for this patient. The physician orders a radiograph, which shows slight elevation of the proximal tibial periosteum. Question could then ask which of the following chromosomal translocations is most likely in this patient. Well, as I'm sure you are listening closely to this video, we know that Ewing sarcoma is most likely associated with the 11 to 22 translocation. But you can imagine in testing, right? They're going to give you all different options. They're going to give you the 14, 18. They're going to give you the 814 translocation. They're going to throw all kinds of numbers at you, right? Maybe the 922, the Philadelphia chromosome. And it's important to have a little memory, a little anchor in our brain to associate which condition, such as Ewing sarcoma, goes with which translocation. For this one, we talked about Patrick Ewing as a famous basketball player because his last name is Ewing. That'll help us remember the Ewing sarcoma. And his number will help us remember the translocation that is present. So just a quick summary to wrap up this video. We're talking about Ewing sarcoma. This is one of our malignant bone tumors, typically going to be in a younger white male. And it's important to contrast the aggressive early metastasis of this tumor with something like a chondrosarcoma, which has a low metastatic potential. Presentation typically going to be in the diaphysis of the long bone, but can also be seen in flat bones such as the pelvis. This can present with pain and swelling along with B symptoms, but the key here is to know the diagnostics. The X-ray is going to show this kind of onion skin appearance due to the periosteal elevation and the lytic bone lesions, but you can see this being a darker area compared to the bone higher up. Important histopathology is going to include these small blue cells, right? We know that our differential for this condition, just based on the small blue cells, can include other things such as chronic osteomyelitis or lymphoma, but Ewing sarcoma is another condition that can have this presentation as well. When we think about chromosomes here, we have to remember the 1122 translocation. I give that as a sample question here because they love to ask that type of question. It's a nitty-gritty little detail, but it's important that we know those numbers to get our questions right on test day. When we think about our management here, it's important to know this is a malignant bone tumor. This is often going to need surgical resection and chemotherapy, and may even need radiation as well.
Welcome back, everybody. David here again with Med School Bootcamp. So to wrap up this chapter, we're going to do a little bit of a summary video where we really break down some of these benign bone tumors. In the next slide, we'll talk about some of the malignant bone tumors. This is really just a general overview video. Won't take too long. If you want detailed looks at all of these individual bone tumors, go ahead and check back at the earlier videos in the chapter. This is really just a summary. The night before your test, the day before your test, whatever it may be. Hey, how do I refresh myself on what these bone tumors are? What are the high-yield things I need to know to get my questions right on test day? Remember, a benign bone tumor is a localized, slow-growing tumor that may or may not need treatment on patients. But when we think about them individually, we really want to focus on a couple key things here, one of which is going to be the epidemiology. We also want to focus on key location, diagnostics, and management. So the first one we're going to talk about is the epidemiology here. And if you remember the video at the beginning of this chapter, we talked about an osteochondroma. We said this is the most common bone tumor overall. It's typically going to be in a 10 to 30-year-old age range. Again, this doesn't mean that a 45-year-old patient cannot have this tumor. But when we think about questions, and we think about board-style questions, they're often classic presentations. So where are we most likely to see this patient? Typically, it's most likely to be seen in this age range. So we want to think about this as we're building our differential. In the first line of most boards' questions is a so-and-so year-old patient, 50-year-old, 70-year-old, 10-year-old patient. We want to be thinking about what range are we in? What kind of pathologies are most likely in that patient's age range. And so that's why it's important to keep this in mind. When we think about our location here, we're dealing with the metaphysis. Remember, the metaphysis is kind of that middle portion of the long bone. If you recall from this nice image we have on primary bone tumors, we have the diaphysis, which is the really long portion of the bone, the metaphysis, which is kind of the middle. I remember the M in metaphysis for middle, and the epiphysis is kind of the end portion of the bone. I remember the E in epiphysis for end. So remember, our anatomy is really important. And then where are these particular tumors located? We're talking about the osteochondroma, most likely to be in the metaphysis. From a diagnostics perspective, this tumor is most likely to show up as a sessile or pedunculated lesion. Again, if we draw our attention to our image, we can see this kind of pedunculated bony growth with the cartilaginous cap growing out of the bone itself. Now, when we think about the management here, these patients do not necessarily need surgery. It's only if symptomatic. However, key point for this tumor is about 1% of them can transform into a chondrosarcoma. And if you recall from previous videos in the chapter, a chondrosarcoma is a type of malignant bone tumor that would need more aggressive therapy. So important to keep in mind, osteochondroma is benign in and of itself, but about 1% can actually turn into a malignant form called a chondrosarcoma. Now, if you draw your attention to the next one, we're talking about the N chondroma. This is the most common bone tumor of the hands. If you see a tumor in the hand in kind of this younger to middle age range, you want to be thinking about an N chondroma. This is most likely to be seen in the medullary portion versus the cortical portion of the hand, foot, or femur. Recall, when we talk about bones, the kind of hard portion out here is the cortex, whereas the middle portion, or the spongy bone, is referred to as the medulla. So we're talking about bone tumors now that are more likely to occur in this middle portion of the bone, or the spongy bone. Now, when we think about the diagnostics here, this is going to be a well-defined lucency on imaging. That is to say, it should have a very clear appearance rather than something that's a little bit more sporadic or chaotic that doesn't really have a defined shape. When we think about the management here, again, as with a lot of these benign bone tumors, surgery if symptomatic. If the patients are not having symptoms and it's just found, you might just do a watchful waiting approach. The bone tumor is not causing any systemic symptoms, so there's no reason to be aggressive with our therapy. However, if things change over time, it might require surgical intervention. The next one that we talked about was going to be the osteoma. The osteoma is most likely to occur in middle age. It's often going to be found on facial or cranial bones, which again is kind of unique to some of these other ones that we talked about. When we think about the location, if we see one on the face, this should be a little bit higher up on our differential just because that's one of the areas it's more likely to occur. Diagnostics will often show a hyperdense and a smooth appearance. And again, surgery can be considered if the patient is symptomatic. Now, moving on to our osteoid osteoma, a little bit of a younger age range here, right? We're talking about 5 to 25-year-olds, going to be seen in the metaphysis or diaphysis. And on diagnostics, it's going to have a radiolucent osteoid core. And so what this means is there's a radiolucent core that's going to appear kind of dark on the x-ray. It's then going to be surrounded by sclerosis, which gives the osteoid osteoma this kind of classic appearance. Again, we have actual x-ray and CT images shown on the video in this chapter, so go ahead and check that out as well if you need a little bit more of a refresher. Again, talking about the management here, surgery is symptomatic, but a key point for this one is that these patients respond to NSAIDs or anti-inflammatories. Why is this so important? Question writers love to ask this particular question because it's in contrast to a very similar but different primary bone tumor. And that is the next one we're going to talk about, which is the osteoblastoma. We talk about the age range here again, typically a younger patient. This one's more likely to be seen in the vertebra or the diaphysis. This is going to be a well-demarcated cortical tumor. Again, we talked about the cortex versus the medulla. These patients will also get surgery if symptomatic. However, this bone tumor does not respond to NSAIDs. So this is the key contrast between the osteoblastoma and the osteoid osteoma. If a patient has osteoid osteoma that is causing them pain, they take anti-inflammatories, they report the pain gets better. If a patient has an osteoblastoma and they take anti-inflammatories, they report no changes or minimal improvement in the pain. Again, a key contrasting point that the board writers love to ask you about on test day. And finally, to wrap up our benign bone tumors, we have the giant cell tumor, typically going to be in quite a wide age range, 20 to 40-year-olds on average. Again, a 10-year-old could have this, a 50-year-old could have this, but on average, this is the age range that we're thinking of. This is going to be in the metaphysis and or the epiphysis of the bone. And on imaging, you're going to see an osteolytic multicystic lesion, which can also be called a soap bubble appearance. When we think about the pathology here, we see something unique called giant cells. And this is important because this is called a giant cell tumor. But this is an important histopathologic finding because in this pathology, you get overexpression of rank L expressing cells, which are neoplastic. These lead to the giant cell formation, which if seen on pathology can make this diagnosis much more likely. Now, I want to turn our attention to some of the malignant bone tumors. And so the three primary ones I want you to know that we talked about in this chapter are going to be the osteosarcoma, the chondrosarcoma, and the Ewing sarcoma. We're going to break this up in epidemiology, location, diagnostics. We're going to talk about radiographs and histopathology. It becomes a little bit more important with these malignant bone tumors. We're more likely to get a histopathologic sample because it may change how we treat the tumors compared to some of the benign tumors we might just settle with the imaging itself. And then finally, we'll also talk about the management. So first, let's talk about the osteosarcoma. The epidemiology is going to include a bimodal age distribution, 10 to 30, and then greater than 60. So again, this means there's not a lot of cases early on, then there's a spike in cases in a certain age range. There's not a lot of cases in kind of the middle age, and then there's a spike in the cases as patients get older as well. This is called bimodal, bi meaning two, because there's two primary areas where we'd expect to see, or two primary age ranges we expect to see this pathology. Now, when we think about the location here, typically going to be in the metaphysis or the middle portion of that knee region. Again, if you draw your attention to our primary bone tumors, we have the osteosarcoma, more likely to be in this area right here, which is going to be the metaphysis. Now, when we think about diagnostics, and particularly the radiographs, we're going to see a couple of things, including a sunburst pattern, Codman triangle, and osteolysis. So the idea here is that as the tumor expands and grows, it actually causes the periosteum of the bone to lift up. And if it lifts up from a couple different areas, you can get this triangle type appearance. And so again, as this tumor is growing, the periosteum or the outside of the bone gets elevated with it. And the elevation of that periosteum can kind of create this triangle appearance. Additionally, the sunburst pattern is the idea that you get these fibers that grow out with the tumor. And we talked more about this in detail on the actual video. However, this kind of gives an appearance of the sun bursting or kind of coming over the horizon on X-ray findings. On histopathology, you get these pleomorphic or different shapes and sizes. Osteoid producing cells, these are known as malignant osteoblasts because they're producing too much of it, right? Normally we have osteoclasts and osteoblasts working in tandem to balance out our bone. But if this balance gets out of whack, if we have too much osteoblasts, we're building too much bone, which can lead to this bone tumor. Now, when we talk about the management here, it's going to depend. Is this a primary cause which can respond to surgery or chemotherapy, or is this due to secondary causes? Again, more details on this in the video, but primary osteosarcoma has an unknown etiology, whereas secondary osteosarcoma can be due to a variety of different things, including radiation exposure, Paget disease of the bone, retinoblastoma, bony infarcts, and some other things as well. Now, let's turn our attention to the chondrosarcoma. This is typically going to be in an older patient greater than 50 years old, often in the medulla of the femur, humerus, pelvis, or ribs. And the radiographic findings are going to include intralesional calcification, sometimes called a popcorn appearance, in addition to osteolysis or the moth-eaten appearance. The histopathology is going to show things like peripheral calcification or hyaline cartilage nodules, which are unique findings to this pathology. The treatment here again is going to be considering surgical excision with or without chemotherapy, and you may consider radiation therapy as well. One key point I want you to compare and contrast here is in the benign bone tumors, a lot of our treatment options were to watch and wait. If they're asymptomatic, they might not need intervention. Notice when we talk about the malignant bone tumors, we're not talking about a watch and wait approach. This is often surgery, chemotherapy, radiation, a much more aggressive therapy for a much more aggressive tumor. And finally, to wrap up this video, we're going to talk about Ewing sarcoma. So Ewing sarcoma is often going to be seen in a younger patient population. Key point here is that this has early metastasis. This needs to be treated aggressively early on in a patient's presentation. When we talk about the location, it's typically going to be in the diaphysis of long bones, particularly the femur, but it can also be seen in flat bones, such as the pelvis. This is also going to have an osteolysis or moth-eaten appearance. This just means that the bone has been consumed in various areas. It's not as sclerotic as it once was, which kind of gives it this moth-eaten appearance. This is also going to have an onion skin appearance as well, and the onion skin appearance refers to that as the periosteum grows outward from the bone and the tumor grows, it can kind of create this onion skin appearance based on the fiber orientation. On histopathology, we can see the anaplastic small blue cells. Now, important to keep in mind here, we can't confuse this with some other pathologies that would also include small blue cells, such as a lymphoma or potentially chronic osteomyelitis. This is why we have to use the entire patient presentation and not just one individual component when making an official diagnosis. Finally, we're going to talk about the management here. Again, surgical resection with or without chemotherapy, as with a lot of these other malignant tumors. So that's just a general overview of our benign bone tumors and the malignant bone tumors that we talked about in this chapter. There are more to choose from, of course, but these are the most high yield ones that you're most likely to get asked about on test day.